Welcome, everyone, to Misconceptions. I am thrilled to be joined today by Dr. Esther Rollhaus. Welcome.
Thank you so much, Dvora. It's so nice to be here. I am a listener of your podcast, and
Oh, a fan.
it's an honor to get to be here. You're doing amazing things for the community.
Thank you. Thank you for being a part of it. So, I've been thinking about our conversation today, and one of the things that I think is quite fascinating in general psychiatry is kind of, I would say, almost like the abundance, the learning, the way things have changed around diagnosis, and
Mhm.
especially in terms of diagnosis of pregnant and postpartum women. And I think we'll start with first. I want my audience to know who you are professionally. And then we're going to take a turn into the conversation around attention deficit disorder, ADHD, how we term it today, how it looks in women, treatment, et cetera, et cetera, et cetera. So why
Got it.
don't you start? Tell us about yourself.
Sure. So I'm Esther Rollhaus. I'm a psychiatrist. I originally was trained in child and adolescent psychiatry. So what that means is you do general adult training, and then I went on to a 2-year fellowship to study children and adolescents. And I found that perinatal work or work with women is speaking to me. And I think about it as preventative child psychiatry.
Yes. Ooh, I
Meaning
love the way you say that.
so I'm like,
Yes.
I'm still doing child and adolescent psychiatry, but with their moms.
Right. Amazing. Amazing. And to be clear, there is no board certification yet in perinatal or reproductive mental health. So really the way that our psychiatrists are coming to do this kind of work is experience and kind of that shemush, that working with under
Yes.
somebody else and guidance. Where did
Mhm.
you get your perinatal information? Like where did you develop that training?
Sure. Sure. So kind of all over the place. PSI, where I've gone to a couple of your talks. ASRM, which is the American Society for Reproductive Medicine. That's where I got to learn more about infertility, pregnancy loss, and those kinds of issues. Their Project Teach is a free resource for New York. I believe any physician can access it. So they give trainings. And so I've attended multiple of their trainings. And then you can ask questions through their hotline, um, which again, for free, which is fantastic. So if ever I have a question that feels too difficult for me, I ask them. And then from that, I've extrapolated to other cases.
Right. Right. And I think that that's really I guess maybe that's probably the way that most of us are really learning beyond the formal didactic is learning from others who are doing this work. And to so let's talk a little bit more about the I think the one thing that's kind of funny to me when you talk about that idea of like I'm working with women versus working with the children. I have often had students in my MSW program who will say to me things like, well, I have no desire to work with, I really only want to work with kids. And I'm like,
Yeah.
who do you think are the mothers of the children in kindergarten who are utterly
Mhm.
dysregulated? Or has anybody asked when the newborn was born in the household so that the kid looks like there's neglect, but really it's just a lot of overwhelm at home, right? Can
Yeah.
we look at this as more of like a family systems issue, perinatal and reproductive support? So I always like have a
I
good laugh,
100%.
right? And they're like, oh, I never really thought of that. I'm like, first question I want to hear about that kid in kindergarten is when was the last time a new baby was brought home? So I
Mhm.
think we're on point. Um, okay, let's talk about ADHD. So, first of all, in your perspective, are we calling this ADD? Are we calling it ADHD? What's the current kind of trend?
So we're going to call it ADHD. The DSM, which is kind of like the Bible of psychiatry, has named it ADHD, attention deficit hyperactivity disorder. You can have it without hyperactivity, which is called inattention type only, or you can have it with hyperactivity. And that's called, and that they're both called ADHD with those two specifiers. And then there's a combined type, which most people fit into, where they're inattentive and hyperactive symptoms.
Okay. And so before we break down like what that actually looks like, I want to explore why I'm interested in hearing more about this. And the main reason that I think that this is like a top topic for me is that when we learn about ADHD, we really see it more from a child diagnosis. I know really typically it is diagnosed. There has to be like some level of representation in childhood. But what I find so fascinating is that when we begin to hear women tell their stories, and we begin to hear what life is like for them and the things that they're beginning to find incredibly hard,
Mhm.
especially in pregnancy and postpartum. We are really, I'm definitely beginning to understand more about the implications of this diagnosis. and the non-diagnosis, because often it looks so different in the female versus the male presentation, even in childhood.
Yes.
And then beyond that, on a very practical level, is I think that treatment of it becomes a little bit more complicated in the pregnant and postpartum women.
Mhm.
And as I've seen and learned from my psychiatrist friends and mentors, is that, while we're very comfortable prescribing things like SSRIs in pregnancy and postpartum, we're a little bit more like, does she really need it when it comes
Mhm.
to pregnancy and breastfeeding? When it comes to ADHD medication. So
Yeah.
that's why this conversation to me is incredibly relevant. I also have to say that from a sociological perspective, I think that we often minimize the impact on women, on how hard it is for them to navigate this world when they're dealing with this. So
Yes.
let's back it up,
Yeah.
okay?
You
What
said
does
everything
this
I was
look
gonna say,
Okay,
so
good,
so
perfect.
we'll go
So
we'll go
thank you so
from the
much for
beginning.
talking. We're gonna be okay. Talk to me about what this looks like from a diagnostic perspective without all the
Mhm.
clinical terminology, but whatever you choose to put out there. What
Yes.
does it look like in girls? And then
Uh-huh.
what does it look like in women?
Okay, so we'll start with children in general, of what it looks like in general. It has what I would say four main components. So it has the inattentive part, where it's hard to pay attention, focus is limited, hard to shift tasks, so the attention gets stuck, and it's hard to turn to a different task. There's the hyperactivity, which we often think of associated with boys. So these are the boys who cannot sit in their chair, who are pulling the hair of the person next to them, who are
Ants in the pants.
chattering away. Yeah,
Right.
exactly. And those
Mhm.
guys are going to get picked up right away because whoever is teaching that class is going to notice that they're disruptive. They're going to send them to a child psychiatrist and they're going to be diagnosed and receive medication. So those are the hyperactivity symptoms are the ones that we can see the easiest. Um, I also think about impulse control issues when we're talking about ADHD. So it's not just hyperactivity and inattention, it's about being able to curb our impulses, getting time between the thought and the action. And so you'll see sometimes that there are people with ADHD who are interruptive. They have the thought, they have to say it right away. Or you can see kids who are having temper tantrums or having behavioral outbursts immediately after not getting what they want. So in response to limit setting, within seconds, they are already on the floor tantruming. Um, okay, so that's impulse control, and that has a lot of emotional, social um, parts to it. And I think we should talk more about the emotional and social parts of ADHD. And then finally, executive functioning. And this is, I think, hopefully hitting the nail on the head of the difference between children and adults. So, executive functioning refers to everything that we do that makes us a thinking, functional person in this world. So, that's things like time management, it's sequence of ideas, thoughts, um, preparing multi-step tasks and figuring out how to do that in a sequence. All of those complicated things that we do to function in the world are part of executive functioning. When a kid comes to me, it's usually with either the complaint of inattention, hyperactivity, or impulse control because the parents are scaffolding all the executive functioning, right? What are the demands for this child? I don't know, they gotta get the knapsack at the end. But if the child is struggling, messy, so mom's packing the bag the night before, right? And putting the coat on and saying, okay, here's your backpack, let's go. So their demands on executive functioning is minimal. As they get older and they start to have to move classes, remember which folder, that's where you start to see those symptoms come out. And very much in adulthood, where we talk about adulting as if it's no big deal, that demands so much executive functioning. And what I would argue is the most executive functioning is being a mom, is doing these chores.
For
That's what
sure.
that's what I would argue. And so that's where you're seeing this come out most of the time in adult women. So sometimes it's a case where someone has started medical school and the demands have become too high in terms of inattention, but most of the people that I'm seeing are struggling to organize the family, to initiate tasks. So they may have very complex tasks that they need to do. They cannot start folding the laundry, for example, and putting it away. That is just too much. Um, I would say that packing a diaper bag is one of the most demanding activities
Oh
in
my
terms of
gosh.
executive functioning,
Yeah.
right? You have to remember what you
Oh,
used last time.
Yeah.
It's
Wait,
that's very
I
hard.
have to use this. I'm going to use this as a case example. So I had a woman who said to me, we talked about like getting out of the house and going downstairs and just like
Mhm,
going to meet a friend at the park. And she said to me, she was able to acknowledge that the idea of packing the diaper bag,
mhm,
figuring out how to get the stroller down the
mhm.
stairs, and how do I get the baby from upstairs to downstairs?
Yes.
By the time I'm at the bottom of the stairs, I'm exhausted. I
Mhm.
have not, and I still may not have enough time to go to the park. So
Yes.
all of this emotional and investment in just getting that diaper bag
Yes.
ready and down the stairs was
Yes.
enough for her to say, "I can't do this," or "I don't know
Yes.
how to do that." And for others, it's
100%.
kinda like, "What are we talking about? I don't understand. Why is this so hard for you?" Right?
Right. Right. And we
Powerful.
don't wanna minimize the experience of somebody who's struggling with the organization and the multi-step planning that it takes to get out of the house.
Right. And so why is this being missed though? Many of these women I think are being missed in childhood. And I know it's a
Yes.
little bit more complicated to give them an ADHD diagnosis in adulthood, but what are we missing other than the fact that parents have kind of resumed some or assumed some of that responsibility? Does it change as they get older? Does their brain functioning is it different when they're older?
Yeah, so in the 1990s or the early 2000s, which is the cohort that we're seeing now, there was not an awareness of or as much of an awareness as the inattentive parts of ADHD. And so if girls were behaving, and they were sitting in their seats and they did not have hyperactive symptoms, they were missed. And that is the way it generally presents in girls is more inattentive symptoms.
Mhm.
And so if there's a child daydreaming and not on the right page, it's harder to flag that child than the one who is jumping up and down on their chair.
Right.
And so many more boys have been diagnosed than girls. And it was about a 3-to-1 ratio, boys to girls.
Hmm.
I read a study. There's also bias here. There's also bias where they took um, a vignette, so a case about somebody who had ADHD, and they gave it a boy's name and a girl's name. And the boys' names, let's say, John and Jane, the boys got diagnosed with the same vignette at a higher rate, a significantly higher rate than the girls.
Wow.
Mhm.
Wow.
There's
Fascinating.
bias here.
Interesting. I wonder what prompts that. I have to think about that more. That's
Same,
fascinating.
same,
Fascinating.
same, right?
Okay.
It's not just detection bias. We have expectations of how girls behave and how boys behave,
Mhm.
and what the ADHD diagnosis looks like in both.
Okay. So when we're looking at a woman who's now trying to get these executive functioning skills are clearly in deficit and really struggling. When I hear you describe to me, she has a pile of laundry, just cannot initiate the task.
Yeah.
Tell me how you're differentiating that from lack of motivation due to depression, right? Because
Mhm.
to me, like that would sound like a depressive symptom. I
Mhm.
just can't get moving. I feel like I'm in mud. How are you
Yes.
differentiating that for a woman?
So that's always something that we're going to be thinking about, right? So is this ADHD? Is this um, depression, right? The amotivation that comes with depression. It depends on the context. It depends on the other circumstances. So is the fact that the woman can't fold the laundry also because she can't get out of bed?
Mm,
Because she needs to feeling like she needs to sleep all day, that everything is overwhelming, she's having negative thoughts about herself, feeling hopeless. That's a picture that fits more with depression. Whereas ADHD is going to come with a constellation more similar to what I said of the inattention, hyperactivity, executive functioning, impulse control picture.
mhm. And so what they're doing is perhaps like looking at that laundry. I know I need to fold the laundry. I just can't quite like get myself to fold the laundry. Maybe I'll go get a drink. Maybe I'll come back. Maybe I'll watch a movie. Maybe I'll play on the floor. Where are you seeing where do you see the mindset? I'm just wondering what
Yeah.
that mindset sounds like.
Yeah. I'll say that no one likes folding the laundry, right? That's
Right.
the worst
Right.
part, right? You put it in
Right.
the machine and then you have to do something with it at the end, right?
Right.
No one likes that. And most people, neurotypical people, are able to eventually do it. So if they're not waiting for pile upon pile upon pile to build up, they don't want to do it. But ultimately, they'll say to themselves, okay, got to do it because we need
We
clothes in
need
our
clean
drawers.
clothes. Right.
Yes. People with ADHD, to varying extents, can't do it. They can't. And so they're going to get piles upon piles upon piles, and they know that they have to, but there's a real difficulty with procrastination, where when there's a task that doesn't have a strict deadline, like most of household tasks that need to be done, but don't have to do it by, a specific time. Um, those are the ones that are very hard to initiate for people with ADHD.
Mhm. So like we're not as concerned with, let's say, like primary care of a baby, because those have time limitations. Like you have to pick up the baby when the baby's
Yes.
crying, you have to change the baby
Mhm.
diaper when the baby's dirty, you have to feed the baby when the baby, when there are tears. So those kind of the
Right.
tasks are not the ones that are difficult.
100%. Those are the
Okay.
ones that demand attention in the moment, right?
Got
So
it.
it's not that people can't pay attention to anything. There are times where they might hyper focus, where they can pay attention. What's really hard is shifting the tasks and planning for the future. So if the baby's crying right in front of you, we say, okay, yes, I need to feed them.
Mm-hmm. Mm-hmm.
If you're planning ahead that you're going away for the weekend and you need to pack the baby's clothes, that is so much more complicated.
Got it. Got it. Okay. What are the things that so let's talk about like treatment from a treatment perspective. Actually, before I get to treatment, I do want to bring up the idea of driving, because that was my
Mhm.
first exposure, kind of insight actually,
Yeah.
into certain diagnoses of people that I'm friends with, where I'm like, they all of a sudden I began to identify this was the diagnosis that was missed, but actually presented itself in failing their driving test multiple times.
Mhm.
And then all of a sudden you began to say, oh, this
Mhm.
is what was missed when it was presenting,
Yeah.
because sat very nice in school, didn't have difficulty educationally,
Mhm.
but could not figure out the task of driving, which I think is like
Exactly.
a huge like aware. I remember learning that in MGH and in the Mass General training, and
Uh-huh.
I'm like, wait a minute, why are we talking about driving all of a
Uh-huh.
sudden as a major test? Tell me more about that.
Yes. Well, if you think about what driving demands from you, it demands all those skills that we've named as deficits. So you need to be able to shift attention. So you're looking at the rear view mirror. Now you're looking at the steering wheel. You're looking at your dashboard. Now you have to remember to look in your side mirror, right? That's shifting attention multiple times. That's incredibly difficult for someone to remember to do that if they have ADHD. So
Right.
someone may, for example, and then there's impulse control, right? Driving demands so much impulse control. So I want to go backwards. I know how to put my, gears into reverse. I just go. Oops, I forgot to look in the mirror.
Uh-huh.
Right.
Uh-huh.
And so you can see how these skills are the hardest, that they're most involved in driving, are
Sure.
exactly the difficulties that people with ADHD have.
Right. And then that was one of the examples that was presented, as that this would be reason enough to keep a woman on medication through
Yep.
pregnancy,
Hmm.
because of the risk of her driving inattentively or in a more dangerous way.
Exactly.
Okay.
Exactly.
Okay. So let's talk about from a diagnostic perspective. Once we have this diagnosis through, somebody has looked and seen it, and really clearly this is not depression, this is not anxiety, this is ADHD or a mix of some other things that have shown
Mhm.
up because of the feeling of being in deficit all the time, frankly.
Mhm.
I think we
Yes.
can begin to feel like that lack of self-efficacy, that disappointment in
Mhm.
self that shows up. What is our treatment option when we're talking about a pregnant woman?
Okay. So, in general, the treatment for ADHD are stimulants versus non-stimulants. There's a little bit of a complexity to it, so I'll try to be as brief as possible. Stimulants are what we think of in terms of Adderall, and Ritalin. Those are the main ones that we've heard of, and generally the side effects are loss of appetite, insomnia. It's giving you a boost actually. So some people who don't have ADHD might actually feel energized by it, kind of like coffee. People with ADHD actually feel more organized on it and more able to initiate tasks. And these are very effective medications that generally work very well. You can see the onset of action, it's quick, and the offset of action also quick. Whereas the non-stimulant options are what I would call, let's say, gentle and don't work as well. So, meaning that you're not necessarily seeing an on or off. They're generally 24-hour medications. They don't have the same side effects in terms of insomnia or appetite suppression. And whether they work is variable.
What are some of the names of those medications?
Guanfacine, also called Intuniv, clonidine, sometimes called Capve, atomoxetine, that's name is Strattera, and then there's one new on the market very, very recently called Qelbree.
Something like Vyvanse is more in the first category?
Correct. That's
First
that's an
category.
amphetamine. Yeah.
Okay. Right. So basically those are uppers, right? That's
Yeah,
that's kind of the way we talk
exactly.
about them. They are uppers.
Yes.
They are alert,
Yes.
they're awake, they cannot, they're not taking naps in the afternoon.
Absolutely.
Okay.
Absolutely.
Okay. And so what are the challenges that we have in treatment relating to a pregnant woman?
Okay. So I love your guest who talked about benefit versus risk versus risk. After I listened to that episode, I started using it all the time. So
Amazing.
I
God
almost
bless
was
Rachel
copyrighted,
Schmutz.
but thank you. Yes, please.
Yes.
Yes, please. It's wonderful. So when we're thinking about giving any medication to anybody, we're always thinking risk benefit, right? Well, there are side effects to the medication. Yeah, but it's going to help them with X, right? With what we need them to do. And so we're weighing, does the benefit outweigh the risk when we're making a clinical decision?
Sure.
In pregnancy, we think about it as benefit versus risk versus risk. And the added risk is the risk of the untreated disorder.
Mhm.
And so in this case, that would be ADHD. How much of impairment is the ADHD causing for this particular woman that justifies the risk of the medication? And we can talk about the data on that, and will hopefully be less than the benefit to her.
Okay. Let's talk about the data on it. I want to explore that because I think it's
Yes.
really important because clearly it's different than the SSRI
Yes.
trajectory that we feel so much more confident in prescribing.
Mhm.
And yet we continue to hear the ADHD hesitation.
Yep.
How much of that is provider bias? I'm wondering,
Mhm.
and how much of that is like, well, she'll be fine versus
Yes.
acknowledgement of the distress that comes along with not being
Yes.
fine.
Yes, and ADHD bias. Yes.
Yeah.
So, um, sorry, can you go back to the I
Yeah,
got
yeah,
distracted by my
right.
head. Yes.
Just like this idea of like what is the data on these
Yes.
medications in particular?
Yes, right. The reasons that we're less comfortable or a little bit more hesitant than at prescribing them during pregnancy is because there's less data. So SSRIs have been around since the 90s. They've been studied and studied and studied. The babies who have had SSRIs in the 90s are now, 30, right? So
Right.
we've had a lot of data looking at their safety profiles.
Okay.
Stimulants have been studied less. There definitely are studies that are done, but every perinatal study has to be done retroactively, which is not as good as what we usually do, which is a placebo controlled trial,
Right.
right? Where somebody will get the drug, somebody will not get the drug. We're able to follow them, see what happens, and being able to analyze the factors and the variables. This, unfortunately, is a retrospective, is not as good, where you are looking back at a cohort of people who were born. Some may have had symptoms, some may not have symptoms. And what medications did mom take in pregnancy? That's
Okay.
essentially the questions that we're asking. It's not solid data. So what we want to do is we want to have a lot of it, right? We want to get it over and over and over again. And the reason providers are more hesitant to prescribe is because we haven't seen it over and over and over again. There's just less information.
So we wouldn't be having this kind of conversation necessarily in 20 years.
A
Like 10 to
100%
20
would not.
years, we'll have
Yep.
way more, collection of data information, the
Yep.
information to be able
Mhm.
to hopefully tell us these are just as safe or just as at risk in
Yes.
terms of the SSRIs.
Right.
Okay. And
Mhm.
so how do you make the decision to prescribe? Because talking about, let's see, either provider bias or ADHD bias or like let her just
Mhm.
handle it bias, how do we
Mhm.
assess for that in terms of this conversation with our clients?
Yeah. So generally the idea is kind of, can she tough it out during pregnancy? Meaning, the risk of the medications, nothing is coming up specifically, but we just don't know. So is it worth taking that chance for that risk for her treatment of ADHD? And so we're going to ask ourselves, how functionally impairing is this ADHD?
Right.
I put in the ADHD bias because there's an added, people at this point are not saying get out of bed with depression. We've figured out that that's not possible. And there is a bias with ADHD of like, just organize yourself,
Right.
just
Just
fold the
fold the
laundry,
laundry.
right? Just fold the
Exactly.
laundry. And I
Right.
think there's also a devaluing of women's tasks sometimes. Anyone could be doing these tasks, but tasks that are specifically assigned to women most of the time, where we're not valuing them as much. So we may take into account somebody who has a job and a working job. Sorry, not a working job.
A
A
job outside the home
a
outside the
job
home,
outside the home that's
right?
compensated, right?
Right?
Where the value is very concrete. And we might say, you know what, she can't perform on her job. We don't want them to lose $100,000. We got to get her treatment. Whereas we have a bias against the jobs in the house that don't have a concrete value, but are very valued by the family.
Right. Right.
And so when we're assessing it, we need to take all those biases into account.
Okay. And then I have to push here as well, the acknowledgement of what does it mean to be a person with ADHD. And with these challenges, it's not a neutral experience for them. It's not
No.
only experienced by others who don't like the fact that the laundry has piled up. It
Yes.
erodes the sense of efficacy, confidence, my
Mhm.
value in the world. I might feel depressed about the fact that I'm really, really struggling.
Mhm.
Let's talk about like what are we have to acknowledge the implications of not treating, especially when we have
Mhm.
a known diagnosis, right?
Yeah.
She has this diagnosis. She does well on medication. We hit
Mhm.
pregnancy and we're like, let's see if you could white knuckle your way through it.
Mhm.
But can we talk about the consequence of untreated mental health condition or and this is one of those, this is a
Mhm.
condition that is in our DSM. This is a
Mhm.
mental health diagnosis.
Mhm.
Let's talk to me about what you would imagine the consequences being of a woman who
Mhm.
has a diagnosis and doesn't have or chooses not to have access to treatment.
Yes. So ADHD comes along with it depression and anxiety very often. They're very, very common diagnoses that accompany ADHD. And it doesn't, there are chemical reasons why, but it also doesn't take, chemistry to really explain why someone with ADHD may feel depressed, that their house is messy because they just couldn't do X. And there's a lot of self blame. Those kind of comments that we said, like, why can't you just? That's in their heads also, right?
Sure.
Why can't I just get this done? I said I was going to organize this cabinet. Why can't I? Right? There's
Right.
something wrong with me. And then we can go into a shame spiral about that.
Right.
Anxiety also comes from the um, instability of living in a world that's unpredictable, right? That someone doesn't feel necessarily in control of. And so somebody might be compensating for deficits in executive functioning by making mental lists all the time, right? Okay, don't forget this, don't forget this, don't forget this. That's anxiety,
Hmm.
right? It's helping them accomplish the task, but it's anxiety provoking. And so we could see potentially a pregnant woman who's not treated for ADHD having those symptoms while she's pregnant, feeling anxious all the time, not in control, not self efficacious, shame. Those are all feelings that might accompany untreated ADHD.
And I can imagine also that might mean, let's say, a reduction in or an increase in the frequency of missing doctor's appointments, missing
Hmm.
the appointments that her prenatal care might decline. Maybe some of her
Hmm.
nutrition or
Hmm.
nutritional intake might decline because she just hasn't been able to put food
Yep.
together for herself.
Hmm.
And she can has enough to get to work, but nothing else. I
Yep.
imagine those are the things that we would see declining in
Hmm.
pregnancy.
Absolutely, which all can be dangerous and lead to negative outcomes themselves.
Right, right, which is really part of this broader conversation of valuing her, like
Hmm.
really prioritizing who she is and what it means for her to walk in her shoes in this world, independent of what she accomplishes, but as much about
Hmm.
what she feels and how
Yeah,
she walks her
right.
life.
Well, when we make the criteria functional disturbance, that's all about what she can do, what she can't do. What about her internal sense of distress?
Wait, back this up because I think this is really important. When you say
Okay.
functional disturbance, tell
Mhm.
tell tell our listeners where that word is coming from.
It comes from an inability to complete the tasks that someone needs to do.
But you're saying that that's part of the requirement for a diagnosis.
For any diagnosis in the DSM, yes, that's
Right.
that's the key, is that it needs to cause what we're going to term functional disturbance, that the
There
person
you go.
cannot complete the tasks of daily life.
Right. Right.
And if we only look at that, we're missing the distress. We're missing the subjective internal experience of what it's like to white knuckle your way through a pregnancy, through 40 weeks of not functioning optimally or in
Right.
the way you're
Right.
used to.
Right. Which I think is something that I've coming to kind of understand a little bit more deeply, this idea of just because it doesn't necessarily qualify within that functional disturbance category
Yeah.
of diagnostics from our DSM-5, that doesn't mean she's not really, really in distress about any of these
Mhm.
things. Right. So she's taking care of her household. She's functioning at home. She's
Mhm.
miserable. And
Yeah.
she probably has depression anyway, even
Yes.
if functionally she's getting
Mhm.
her tasks done, and I think that's
Mhm.
so important, and what's going on internally, like, I don't know about you, Esty, but I have yet to find anywhere in the Torah that it tells me that there is a mitzvah to suffer, and I
I
think
always say this, at the end of your
right?
life, there's no medal for, like, that you took a little dose of SSRI or you didn't take a dose. There's
Right.
no
It's
medal.
right, it doesn't say it on my tombstone. It also
Yeah.
does not say whether I had or did not have an epidural, just so everybody knows. It's not there, right? I've looked in many different graveyards. My children know I like going to cemeteries. I'm weird that way. But it doesn't say anywhere whether I had an epidural. So, which I did. So, those are the kind of things that, like, you're right. Like, what is it that in the long run,
Mhm.
how are we calculating what's necessary versus not necessary? And are we really listening to her tell us the level
Mhm.
of distress this causes? Yeah.
Yes, absolutely.
Could we talk about executive functioning a little bit more broadly in terms of how you see, especially from your child and adolescent perspective,
Mhm.
that part of your brain. But when we talk about executive functioning coaching or
Mhm.
kind of beyond medication or in addition to medication,
Yeah.
what are some of the things that we've learned are needed in order to help someone with ADHD's brain to
Mhm.
function in a more neurotypical process?
Yeah. So there are options for therapy, specifically behavior oriented therapy, where there's training to be able to create executive functioning tricks.
Okay.
So, using compensatory mechanisms in order to achieve what someone with neurotypicality would achieve without thinking. So, it's essentially the tips and tricks about how to compensate for the deficits that someone may have. So, there are
Okay.
coaches who might, organize knapsacks for people and then teach them how to continuously keep it organized by various like prompts. Like, oh, okay, it's the end of this period. I need to put in this folder, right? It's taking it nitty gritty step by step in terms of scaffolding the executive functioning skills that hopefully the person will take with them.
And so that would be something that if nobody ever taught someone with an underdiagnosis or a lower
Mhm,
diagnosis of ADHD that shows up more profoundly in pregnancy or postpartum,
mhm.
someone's going to have to teach them how to do this as a new parent.
Yes, yes.
Who? Who's teaching them?
I don't know. We need
I
executive
wonder.
coaches who are going to really specialize in
I know.
ADHD in
ADHD
pregnancy.
in pregnancy and postpartum
Yeah,
and right, and work collaboratively with the psychiatrist and the therapist. That's what I have
that
to
would be
say because,
great.
like, I just don't want the coaches out there doing this work. This is not coaching exclusively. Put
Uh-huh,
that in there as a
100%.
as a disclaimer. What else do you want our audience to understand about ADHD in pregnancy and postpartum?
I want to take it cellular for a second, and this is going to get a little nitty gritty, but I want to demonstrate how real this is. We know that estrogen and progesterone have receptors throughout the brain, especially the thinking part of the brain. That part that we were talking about that does executive functioning actually has receptors to estrogen and progesterone. And there's been study after study that shows cognitive differences throughout the month
Hmm.
of the cycle, depending on the levels of estrogen and progesterone. They're subtle, right? But you may see a little bit of an improvement in working memory in, week 2 of the menstrual cycle, for example. Okay, there's something very chemical and biological, and so sometimes I'll find ADHD symptoms worsening in the week before the period, where we commonly associate that with irritability, depression, and anxiety. But this is something that's being reported. It's not very well understood, but it is there in the literature and it's there in my clinical practice.
Huh.
So I want people to understand that there actually is something specific going on in the brain related to pregnancy and postpartum and the potential for ADHD symptoms getting worse.
Fascinating. Would that mean that you are more active, and therefore you may be more active in treating it if we're seeing, like, if we know that there's this added vulnerability, there's more indication to treat it during these time
Mhm.
periods as it's functioning.
Right, right,
Yeah.
which is not the way we've been thinking about it up until now, but as we're
Right.
going more into the basic science, we're seeing evidence that there are physiological changes or psychological changes that are happening from the different levels of reproductive hormones, estrogen and progesterone.
Okay, so now I'm gonna take a hard left. Perimenopause,
Mhm.
where we know that there's shifts in
Yep.
estrogen in our
Yes.
bodies, progesterone, I'm sure as
Mhm.
well. So
Yes.
are we similarly tracking how women who are beginning to decline in their estrogen production because of perimenopause and menopausal symptoms
Mhm.
might that are we potentially
We're
correlating
we're
that
we're
to?
yeah, yeah, we're coming there.
Yeah.
It's something that's already in the literature of thinking about ADHD symptoms worsening around perimenopause.
Mhm.
And we're starting to think about even and we know that estrogen is protective cognitively.
Yeah.
And so it actually seems to prevent some symptoms of Alzheimer's or dementia, actually.
Mhm.
And so there's
Mhm.
talk, and this is not standard of care, but talk about using hormone replacement therapy for the cognitive effects of it.
Which you
Okay.
hear from women who are describing menopause or perimenopausal
Yeah, they
symptoms of
can't
like,
think.
I'm so
I cannot.
scattered, I can't think, I have
Yeah.
no memory, I can't read a
Yep.
book, nothing's sticking. And
Mhm.
oh, by the way, depression and anxiety is showing up all over the place when I've had no
Mhm.
history of that at all.
Yes. Yeah, it's
Mm,
alarming. It's alarming.
yeah.
People can go through their whole lives and not have not be symptomatic, and then all of a sudden, as they're experiencing this normative drop in estrogen and progesterone, it's scary that they start developing symptoms that are alarming to them.
And very often, once again, being told, okay, but like, welcome to the change, right?
I
Welcome. This is just
know.
what it's
Yeah.
like when, oh,
Yes.
welcome to menopause versus like, actually, we treat the
Mm.
symptoms. And if these are the symptoms, we need to treat them.
Mhm.
So, along that line of thinking, what about women? Many women today are on a stable form of birth control for many, many,
Mhm.
many years that is in many ways like hormone replacement therapy, right? Like
Yes.
they're taking a static form of estrogen and or just estrogen or
Mhm.
estrogen and progesterone over many, many years, often not getting a period, not having a cycle, some people with like the Mirena IUD, or just taking a consecutive birth control pack. What
Mhm.
are we thinking about in terms of that question around like, is this protective? Is this helping to maintain some of the vulnerabilities that come with aging?
I don't know that that's been explicitly studied. I can't think of a specific study that's asking the questions about oral contraceptives and having and the cognitive effects, but I would extrapolate that you're not having the same variability in cognition throughout the month. Right? So you're getting a
Mm,
stable dose of estrogen, it's hitting the receptors in a stable way, and so there's not necessarily variability week to week if you're taking continuous contraception. But we don't
fascinating, but we don't
understand how
know.
that's going to.
Right.
Right, but we don't understand how that's gonna translate. Is that gonna ward off, Alzheimer's? Well, like, so what, right?
Right.
No one is taking, like,
Right.
a memory test, like
Right.
in week 2 versus week 3 of their cycles, right? So
I
we
wonder
still don't
also about like,
understand.
yeah. And I'm thinking about like week 40, year 41 versus year 51, right? Is anybody tracking what that looks like over longer periods of time?
Mhm.
Interesting.
I don't know. Yes.
Yeah. Interesting. So interesting. Wow. Okay. Yeah. My brain just went all over the place. You probably saw that. It's fascinating. I mean, I had a conversation with a pelvic floor, well, no, actually with a sex therapist. We were talking about like the reduction of estrogen and how that impacts even like the sexual health of a woman and her sexual
Mhm.
experience. And
Yes.
some of that can be mediated through having this static hormonal infusion
Mhm.
by a oral birth control. That an OBGYN that I consulted with said, yeah, that actually is mitigating some of that
Mhm.
decreased estrogen. It can cause increased vaginal dryness and things like
Right.
that, or it
Mhm.
might affect libido, but it
Mhm.
does have the some of that protective
Yes.
component that birth control is almost being used as hormone replacement therapy.
Yes, and that's emerging at this point,
I think
right?
so.
In terms of the
Yeah.
data, people are starting to talk about this.
Mhm. Mhm.
It's emerging, right? We're
Right.
starting to reference, and it's controversial at this point. It's not standard of practice to give
Right.
at this point to give hormone replacement therapy for the only indication of
Correct.
psychological cognitive symptoms. We don't do that. So mostly what hormone replacement therapy is given to someone for that complaints, for example, of vaginal dryness leading to sexual dysfunction. And then someone may take hormone replacement therapy and incidentally feel that their cognition is better.
Sure.
So we
So
just still don't
interesting.
use it that way,
Right,
right?
right. And this is where the studies will show up in a few years' time, hopefully. And someone will say, look
Mhm.
at this anecdotally, or then let's track this and figure this out. And that's
Yes.
how we learn. And that's how we
Yeah.
learn. All right. What are the top three misconceptions that you would like people to understand about ADHD? Let's blow through some of those misconceptions.
You cannot just white knuckle through it.
Yeah.
It's not just like pick up your lawn, do it, right? Just do it.
Just do
It's
it.
not. This is a disorder that is from your brain. It's from your
Okay.
brain. It's not the type of thing that you can talk your way out of. The same way we've accepted that about depression, we
Yeah.
need to understand that about ADHD too.
Okay. Number two. You have a second one for us?
Yeah, I'm thinking real
Go
quick,
for it.
but I'm trying. We need to pick up ADHD in girls. We need to understand this, and I think we are doing a better job in terms of picking them up in preschool and elementary school at this point because there's more of a consciousness around how girls present differently.
Mm,
And we're able, for the most part, to examine our biases of what a girl should be, what a boy should be. There's becoming more flexibility around that. And so it's easier in some ways to pick up the diagnostic differences.
fascinating. Fascinating. Okay.
All right, last one. I have so much. Okay, I'm going to say the pregnancy piece. It's kind of
Yes.
back to the first one, but looking at risk versus benefit of these medications. And what is the risk, both functionally, but also in terms of subjective distress to the woman if they do not take medications in pregnancy?
Yes. Yes. And that we really need to hear that voice. We really have to
We
hear that
do. We
voice.
do.
We
We need
do.
to speak up about that.
Oh, I love that we're talking about this. Essie, thank you so much. This was a wonderful conversation and so meaningful. And I know it's one that really needs to be heard. So thanks for
Yes.
spending some time with
Thank
me.
you. Thank you for giving me a platform. It was so fun to talk to you.
Absolutely.